Good morning, sirs and ma, Dean of Dentistry. Good morning, sir. I would like to please request that we stand up for the national anthem as we start this scientific session. IT, please.
We hail thee, our own dear native land. Though tribe and tongue may differ, in brotherhood we stand. Nigerians old and proud to serve our sovereign fatherland. Unibadan from the land of truth and independent sound. So this great for all who thirst, loves of knowledge to advance, pledged to serve our cherished goals, self-reliance, unity, love the nation, live with pride, love to build the world. Life is truly free. Unibadan first and best, let's unite for a noble cause. Social justice, equal chances, greatness one with honest toil. Pride our people, this to know, wisdom's best to set its turn. Love and shine our eyes to learn, for my path knows wisdom born thus Give all the college of medicine, keep the call. The train raising hands for the poor. Training, bringing up to date, knowledge for all. Through God our Creator we learn to say, Salata Velosa for His praise. Bring on the glory of our noble star. In all the knowledge of medicine, in the call. Center of excellence, the best of all. Center of excellence, the best of all.
We may have our seats. Good morning, ladies and gentlemen. It gives me great pleasure to welcome everyone to today's scientific session of the 50th anniversary of the Unibadan Dental School. As we start out, I would like to quickly recognize the presence of the Dean of Dentistry, Professor Bamidele Kolude. Thank you for joining us this morning. Also, I'd like to recognize, thank you very much, sir. I'd like to recognize the presence of one of our pioneers today, in person of Dr. Adijoke Fatunde. Thank you for coming, ma. We are very happy to have you here. We have head of departments here with us, the head of Department of Oral Maxillary Surgery, Professor V.I. Akimoladun. Thank you for coming. Thank you for joining us this morning. Professor Dr. Gbadebo is here with us. Dr. Professor Lawal. Okay. Professor Atisa, thank you very much for joining us this morning. Also here with us are senior members of the faculty, Professor A.O. Fashola. Thank you for joining us, sir. Professor Ajayi, the the LOC chairperson. I want to use something more. Thank you very much for what you've been doing. My Professor Lasisi is the head of the scientific committee for this 50th anniversary. Thank you for joining us, man. Also here with us are some of our alumni that are here present already. Dr. Olakunle Johnson, thank you for joining us, sir. Dr. Feyi Ikushika, thank you, sir, for joining us. Also here with us, Professor Shofura. Thank you very much for joining us, ma. Also, our friends here, I would like to specially recognize the presence of Dr. Adeola Absalam. Thank you for joining us. And I'll still do some more recognitions as we go on. I would like us to start. We are actually running behind schedule. This science session is actually in two parts. We have oral presentation and we have the poster presentation, which is already displayed outside. For the oral presentation, the chairman of the oral presentation session is our own Professor A.O. Fashola. Please come to the table, sir. Let us encourage him. Thank you, sir. And our rapporteur for this session is no one but our own Dr. Francis Oluseyi Ikushika. Please join us. Olufeyi Ikushika. Thank you for coming. I would like to invite the presenters that are here present to please come to the front so that we'll easily be able to call you Dr. Gbadibo, Dr. Salami, Dr. Absalam, Dr. Shitu. As many of us are present here, please let's move to the front row. The front row. As many of the presenters should move to the front row. Thank you very much. I'd like to hand over the proceedings to our chairman, Professor Oyo Fashola.
Thank you, Dr. Aladelusi. As they introduced, our time has gone, so we want to start immediately because there will be another presentation at about 10:20, and that's going to be online. But just permit me to say, that we have assessors for the posters and for the oral presentation. They are going to assess the oral presentations and the posters. So, and these assessors are Professor Victor Akimoladun and Dr. Olakunle Johnson. So please, I want you to sit down there, sirs, so that, in the course of the presentation, maybe you may have to talk. You can come to the front, sirs. I hope you are not assessing the chairman and the rapporteur also. Just the presentations. So thank you. But before we start, I have to say this, that one person that has had an impact upon our life, or my life personally, is here. She has been introduced, but I want to reintroduce her because she taught me orthodontics, mathematics of orthodontics. She taught us mixed dentition analysis. And I was just telling her in the morning, that I scored very high there. Maybe she doesn't remember. And that is in person of Dr. Adejoke Fatunde. Please appreciate her. So right now we have 6 oral presentations. I think Dr. Ogunsalo is around. Okay, you're welcome, sir. So the first presentation, and each presentation will take 8 minutes. 6 minutes for the presentation and 2 minutes for the questions. So please, audience, as the presenter is presenting for each presentation, let's just make sure that, we write so that we don't have to waste time in the course of this particular program. So the first presentation is going to be on evolution of the oral health model adopted by Dental Outreach for Africa. And the presenter, we have about 5 authors here, but the presenter will be Fatunde A. I suppose that's Dr. Adejoke Fatunde. You can come forward, ma. You have 6 minutes, ma.
Good morning, everybody. The slides are barely up, and I don't know that I can
Sorry, ma.
do-
At the point of 5 minutes, ma,
Oh.
you will hear a tap just to tell you that you should be rounding up.
Okay. So, I'm limited by time, but just read along with me. It's pretty self-explanatory. And this is just about the oral health, the health model that's been adopted by Dental Outreach um, for Africa. Basically, we've done a hybrid of 2 models. The primary model is a biomedical model. Okay, the primary model is the biomedical model, which simply is a cause and effect model. A patient comes with dental pain, and what we're trying to do is figure out where is the pain from and how do we resolve the pain. Yes, the patient. It's not part of my 5 minutes. So we look for what are the possible sources of the pain, identify the sources, and get rid of the pain. Move it to my mouth. Okay. However, this gives immediate treatment for pain relief. We may give antibiotics, extraction, restoration, but might any of this recur? What might limit recurrence is taking into account the ecosystems that surround man, both internally and externally. And when we can address that, then that leads us to think of, okay, the person's biology and physiology. At the same time, you have the external ecosystem, the community, the culture, the society, and the biosphere itself, all of which impacts this person and his or her psychology. And so that leads us to the health belief model, which addresses modifying factors such as age, gender, and all of those in the first column. Then individual beliefs, because whether we like it or not, our beliefs and perceptions shape a lot of what we do and a lot of how we address health behaviors. And all of those will lead us into actions. The health belief model is a psychological model of some sort because the patient has to perceive that there is a threat to their health, either in severity or in susceptibility, and believe that taking action will reduce that stress or has some benefit. And then the bottom line is those benefits must outweigh those threats. If the patient does not feel that, chances are the patient will not take action. Such as we can preach all we want about patients seeking preventive dental health. But when they have to put that against conflicts in schedule, against economics, the cost of treatment, oftentimes that the preventive action is pushed back. So realizing this, it is that the action just must justify the reality of the patient. So the Dental Outreach for Africa has sort of taken on the hybrid of the biomedical model. Of course, we must know what's wrong with the patient and how to treat it, but more importantly, to address factors that affect the ecosystem of the patient, whereby they are then more interested in addressing continuous care, preventive care, as well as timely care. And that's the basis of the model on which dental outreach operates its clinic. So the hybrid is pretty much how can we minimize barriers for patients to take action. And the approach is, one, let's make dental clinics available as close to them as possible so that we remove the barriers of transportation and all of that. And then we got to educate the patients. Why should they even bother about taking action aside from pain? So the perceived benefits definitely must outweigh the perceived threats. What we then did was to look at the treasure that we have in the Deacon Community Clinic. It's a treasure because we were able to access 38 years of records. And what we then did was to look at the patient attendance over 38 years, and we broke them into three. The baseline is from 1987, that was the inception, to I believe 1997, and then 1998 to 2007, and after to 2017, sorry, 1988 to 2007, that's baseline. 2008 to 2017, that's our P2. And P3 is 2007 to date. And then the hypothesis was, is there a difference in total attendance between P1 and P2, and between P1 and P3? We then subjected this to a detailed t-test and found that between in P2 it was we had about 2 point, I can read this too well, but more than twice the attendance was in P2, and definitely more than thrice the attendance was in P3 relative to P1. These statistics definitely was just overwhelmingly very clear that this was significant at 0.01%. And therefore, we were able to reject the hypothesis that there is no difference in attendance. This certainly has served as a motivation. You can see the baseline line and how attendance, even in P3 when we had COVID, still towered over the baseline. And so dental outreach will continue to use this model in terms of educating the patients and limiting the barriers. I see that the chairman already tapped. Dental outreach is encouraged to continue its actions. Right now we are working with 3 dental institutions and have 4 clinics established. Thank you.
The presenter presented evolution of the oral health model adopted by Dental Outreach for Africa. She took us through the biomedical model and his emphasis on pain. And she discussed the health belief model and how this was modified to have a hybrid medical model, and that the clinic at Deacon was used to test this, and the results showed that there was increasing attendance over a period of time. Thank you very much, ma'am.
So we don't know if we have questions. The audience, just 2 minutes. If we don't have, so that we can move on. Questions, comments? As we wait for that, just want to recognize one of our senior colleagues from Obafemi Awolowo University, and that's in person of Professor Morenike Upon, Department of Child Dental, OAU, a campus of University of Ibadan. Any other comments? questions? So I think we need to go to the second presentation. The second presentation is titled Validation of the IDA 4C scale in the assessment of dental anxiety in a subpopulation of Nigerians. Dr. Eso Badebo will take that presentation.
Good morning, everyone, the chairman, all distinguished guests present, senior colleagues. I'm Badebo Shakira Olaide here to present one of our studies titled Validation of Index of Dental Anxiety and Fear, 4C, that's 4 categories in the assessment of dental anxiety. In assessment of dental anxiety in a subpopulation of Nigerians. Okay, that's my outline, and I'm going to be discussing the background. We all know what dental anxiety is about, and it's one of the things that it prevents patients from coming to the dental clinic. And when this occurs, it leads to progress of disease and deterioration of oral health due to the fact that they are afraid of coming to the dental clinics or seeing the doctors. So we actually need to assess this dental anxiety for optimal oral health, and we have to be doing it on a regular basis. But as studies have said, I'm seen, this dental anxiety is not usually assessed among patients. There are so many things, so many tools that have been used to assess dental anxiety, starting with the CDA, the Cora Dental Anxiety Scale, down to the Modified Dental Anxiety Scale. But so many of them, they take different parts of anxiety as they go on. The Index of Dental Anxiety and Fear is one comprehensive tool that was developed by Amifield, a psychologist, and it assesses all the components of anxiety, which is physiological, behavioral, emotional, and cognitive. And it also has another part that assesses stimulus of anxiety as well as phobia of anxiety. So combination of these measurements actually leads to us assessing everything about dental anxiety, and it seems to be or can be a preferable skill over the other ones, and that's why this study was done to assess the validity and reliability of this skill among among patients, among Nigerians. And this scale was also compared with the Modified Dental Anxiety, which has been validated in this environment. It was a cross-sectional survey which was done in the dental center, and ACGIS survey 1, 2, 316 was used. We looked at the prevalence of dental anxiety among the the patients, participants, and this assessment was done with the IDF4C and MDAS. And after that, the two scales were correlated to see if IDF4C can match that of MDAS. The data were analyzed with SPSS. We did descriptive analysis and the validity and reliability scale, and the association between that scale and MDAS was also done with Spearman correlation. The study participants were aged 18 to 75 years. A majority of them fell into low moderate categories of anxiety with IDF4C and the MDAS respectively, giving 70.7% and 58.8%. But the IDF4C, interestingly, gave the same amount of fear, high fear, as well as the MDS scale, which was 11.6% of these patients. The IDF4C questions showed strong internal consistency with comeback alpha of 0.991, and the test result reliability, which was the intral, showed 0.99, and the validity also showed a strong correlation of
0.83, and it was significant. This shows the social demographic of the participants, with the gender being more, with the female being more, and the age group as seen. The mean age was 34.73, plus or minus 14.3. This figure shows the categories, the fear categories using the two tools, and it shows that the high anxiety was seen same in the same set of percentage of people. Then this is the second part of IDF questionnaire, which is the IDF phobia. And this phobia part has 5 questions, and anyone that's yes or no, it's graded with yes or no. Anyone of greater than 3 that says yes is counted to be phobic. The patient is counted to be phobic. Okay, then talking about cost of treatment had a of score with IDF stimulus, and this was seen both in male and female, though it was not significant. However, the female has significantly higher mean score of for site of needle injection, as their stimulus of anxiety. There was also a significant correlation between the two scales observed, and this shows the comparison of the IDF scores and gender. Also, the relationship with the IDF-4C and MDS skills, showing the significant correlation amongst them. Now, the assessment of DA is supposed to be something that we should be doing on a regular basis. It should be something that we should do to improve on patients participating or presenting in the clinic. Since the application of 4-question choral dental anxiety scale is being the basis for modification and advances in DA assessment scales, and this is what all the scales, new scales, are being graded against. So MDS scale is validated and common tool for assessment DA globally in Nigeria, and NDA-4C by this study has also shown that it can be used among subpopulation of Nigerians. And in conclusion, we want to move the regular assessment of patients for DA is necessary, and that we should use appropriate and comprehensive tool to identify and monitor patients with DA in order to reduce morbidity associated with dental anxiety. Thank you.
IDF-4C plus scale in the assessment of dental anxiety in a subpopulation of Nigerians. The GIS survey 123 was used to collect data. The IDF scale was compared with the MDA scale, and it was found to be comparable, if not superior. And there were good results for internal validity, test-retest validity, and the reliability of the scale. And both aspects of the scale had very similar results. Thank you very much, ma'am.
So we don't know questions? Questions, comments? Yes, question. You can take that.
Thank you very much for the presentation. I just wanted to know about how many minutes does it take to administer these tools? I'm just looking at in terms of feasibility of routine care in clinic, because apart from the fact that it's comparable, the duration, how long it takes to administer each of them may also enhance usability in during consultations. Thank you very much.
Thank you so much for the question. The scale actually has 3 sections. The first one that combines all the components of DA, physiological and cognitive, emotional and behavioral. They have 2 questions each. That makes 8 questions. So if you are taking that part alone, it's just about five minutes thereabout to take it, which is comparable even with the MDAS. But the other part, which goes further to check for phobia and stimulus, one is 10 questions, that is stimulus, and they are just about like a skill that I used. So when we have to combine everything, maybe like a minimum of 7 minutes or so, or 8 minutes to do it. Thank you.
Any other question before we go to the next? Okay, thank you, Dr. Gbadebo and the other authors. The next presentation is from the Department of Obstetrics and Gynecology. We are glad to have them here. And the title of this presentation is Perception and Acceptability of Integration of Oral Health Care into Maternal Health Care Services among antenatal health care providers. Let's welcome Dr. Abdusalam, R.A. for that presentation. Oh, Dr. Lagunju, you are the one presenting. Okay.
Good morning, everyone. I appreciate my teachers and colleagues. All other protocols duly observed. Dr. Lagunju is my name, and this is a research finding from our study titled Perception and Acceptability of Integration of Oral Health Care into Maternal Health Care Services among antenatal health care providers in UCH Ibadan. The study was conducted by Dr. Abdusalam I, Dr. Lawal, Professor Lawal, and Professor Lasisi. Can we move to the, okay, so thank you. Thank you. The oral cavity is an integral part of the body and responds to hormonal variations in pregnancy and should not be ignored or considered in isolation from the rest of the body. Evidences suggest that hormonal variations in pregnancy put pregnant women at increased risk of gum disease, which has been associated with various adverse outcomes, such as low birth weight, intrauterine growth restriction, and prematurity. Mothers with untreated dental decay are also likely to pass on the bacteria, especially when they are in direct transmission by phone feeding with their children. So they tend to have the same disease that the mother tends to have in the oral cavity. And oral health complaints are rarely reported and poorly addressed by antenatal care providers, despite being the first point of contact with the pregnant woman. And antenatal care providers have a role to play in the identification and treatment of prenatal health conditions. Now to the statement of problem. Oral health is a critical but often neglected aspect of maternal care, despite evidence linking poor oral health in pregnancy to adverse maternal and fetal outcomes, such as preterm birth, intrauterine growth restriction, also periodontal complication. And antenatal care providers serve as the first point of contact for pregnant women, yet many lack adequate knowledge, training, and practice regarding oral health in pregnancy. So understanding the perception, knowledge, and acceptability of integrating oral health care into maternal services among antenatal providers is essential for improving overall maternal and child health. So what are the aims of this study? Is to evaluate the perception of antenatal health care providers in the integration of oral health services into routine antenatal care services and to identify challenges and barriers to integration of oral health in antenatal care services. So the study was actually a descriptive cross-sectional study carried out among 100 participants who were antenatal care providers. So we had obstetrician, younger doctors, we had midwives, we had nurses who participated in this study. And a simple random sampling technique was used. And the eligibility criteria was that of all antenatal care providers of all cadres who were available at the time of the study, and those who were ill, who were on leave, or those who did not provide consent were excluded. The sample size was that of 94, and it was actually gotten from the p-value of done by a study done by Enabulele in 2014, and it was approximated to 100 to take care of attrition and fallout during the study. Our ethical approval was gotten from the Ethical Review Board of the University College Hospital. Now to the results. Among the healthcare providers, we discovered that about 50, that's almost half of the entire population, understood that poor oral health in pregnancy had negative effects on the woman. Close to about 35 of them did not know anything, whether it had any effect on pregnancy or not. And some believe that it did not have any effect at all on pregnancy. Majority of our respondents believe that routine oral health examination is important, totaling about 81. Knowledge about vomiting in pregnancy causing caries was actually given. Majority, about 45 out of 100 participants believe that vomiting in pregnancy may predispose to caries, and about close to 40 believe that it does not have any effect at all. Now to the perception and acceptability of oral health care in integration into antenatal. We found out from this study that about 96% of antenatal care health workers found integration of oral health as acceptable. So they found it acceptable. About 85% will like routine oral examination to be incorporated into booking during antenatal booking. About 80% actually believe that they would like to have routine oral examination to be done during antenatal care visits. And it is known that about 92% from this study have willingness to inquire about oral health, and about 96% have willingness to counsel patients adequately about oral services, and about 89 are willing to conduct an oral examination on patients during antenatal. Now to the perception and potential barrier. Now about 75 of our antenatal care gigas believe that integration is feasible. About 83% believe that dental examination is better, and about 60% of antenatal healthcare workers feel that it will create additional workload on them, and about 83% believe that they need more training. So in conclusion, study has demonstrated that while knowledge and practice of oral health care in pregnancy among antenatal remains suboptimal, there is a strong willingness and high acceptability for integrating oral health into routine care, and nearly all respondents recognize the importance of oral health in pregnancy, and they express readiness to counsel, screen, and refer patients for adequate, if adequately trained. Integration is perceived as feasible, although barriers such as workload, lack of formal training, and reference for dental specialist training still remains. Thank you very much for listening. These are my references.
Thank you very much, sir. You only spent 33 seconds more. Thank you. The paper presented was perception and acceptability of integration of oral health care into maternal health care services among antenatal health care providers. The background to the study, the importance of the oral cavity, which is microflora, was highlighted. The links between oral health care and pregnancy, both affecting the child, the unborn child, and the mother, were highlighted. Then perception to the barriers of accepting oral health care assessments were all highlighted. Importantly, the methodology was well discussed, the sample size, ethical issues, and the study participants were very clearly stated. And at the end, it was found that most of the respondents felt that oral health care being integrated was important, and they felt they needed more training to be able to implement this. Thank you.
Questions? Comments? Yes. Dr. Johnson, there are very interesting, yes.
In my own time, when we are in school, a posting But I learned that now dental students go to Igbora. Uh, that is very good. Who are your classmates? They are going to give back. Do them know what oral health is all about. Again, it's going to be something that is going to make our idea. And I don't know whether in the college where dental medical students who come to the dental center, hey, that is good. Because thank you very much.
Yes. We saw a hand. Yes. Thank you, Dr. Olakunle Johnson.
Good morning, everyone. Thank you very much for your presentation, sir. I just have a question. You mentioned in your presentation that untreated dental decay in mothers can cause dental caries in the children. Whether I don't know if it's born or unborn children now. I just want more clarification on how that can happen. Thank you.
Wait, let's take the two questions. Yes. You have a question? Yes. Okay. We'll get to you. The paper is generating a lot of comments.
Good morning, and the presenter. This is the way to go. In my own association, Pediatric Dentistry, we have this is a comment. We have emphasized the need to send our residents out to antenatal and child welfare clinics. So this is the way to go, and we are really working on it, and it's going to be included in the resident curriculum. That is going to be part of their requirements to go out. So the part that the worker said is going to be a burden on them, is not going to be on them. We will be sending either students or residents to those places to do the oral health talk and possibly some examination. If we do a talk and we don't have the opportunity of examining, we can tell them to come to the dental clinic. So it is, I was highly impressed that we have presentation from ONG. It's the way we are all thinking. And it shows that health workers were one. Nobody is higher or lower than anyone. The body is one. And it's important that we all integrate together so that we can have the whole body and not just a healthy mouth or healthy uterus or whatever. It's a whole body. So we are working towards it. The most important thing now is our medical students come here for during their rotations. There is this integration. So they have basic knowledge, which was not there like them, Dr. Johnson said. So they come here for their rotations. They have basic knowledge. They come to the clinic, and we expose them to the few things we do. So, but going forwards, more, we will work at it. Thank you so much.
Yes, there is you can come to the front. That will be the last question.
Thank you very much, sir, for the presentation. And because of the collaboration, I can see that it's already generating a lot of. I'm glad about that. So I just wanted to clarify. During your presentation, you mentioned that the sampling was full random sampling. Abilities are all. I was just
Thank you very much. So we that consultant obstetricians, health nurses, that was what we meant by CADA. Not that we included everybody. So that come in contact with the pregnant will serve as a vector for important or correct information for them. Included all of them. Then we had our sampling, including cadres in our sampling frame, and then we select that. That's where our random sampling came from. Thank you.
Thank you so much. I appreciate my teachers for the questions and comments. There's a question that dental infection in mothers, does it affect the baby? Now, like I said earlier, a number of times mothers may want to use the spoon they are using to feed to also feed the child. And in the course of doing that, you inoculate some of the organisms, the flora in the mouth, into the mouth of the child, then the child can have those kind of infection. We have also noticed from literature search that some of the electrolytes we have in our system also affect the mouth. So some studies we did demonstrated that those who are deficient in bivalent ions, calcium, magnesium, they tend to have some medical morbidities. For instance, preeclampsia, UGR, and these cofactors have effects on the teeth also. So if more studies are done on the dental area, it will also help us to even predict possible adverse outcome later in life. Thank you very much. I appreciate it.
So thank you, Dr. Olagunju and his team. We'll be taking another presentation now, but just to inform us, we have an online presentation on AI research, and we know we are in the era of AI. So that will be coming up after this presentation. So it's just a 10-minute presentation from one alumnus, that's Dr. Israel Agaku. The next presentation is coming from Jamaica. And the title is Non-Immunodeficiency Juvenile Periodontitis, Pan-Clinical Attributes and Treatments. The Jamaican study, a 15-year retrospective study. It will be presented by Dr. Christopher Ogunsalu. Let's appreciate him as he comes.
Mr. Chair, thank you for the invitation. Are you hearing me? Yeah. I'll acknowledge that this presentation is a work done by Dr. Yemi Ojo from Unimed and also myself. He's supposed to be presenting, but I'll do it. He's not here yet. The title, Non-Immunodeficiency Juvenile Periodontitis, a Pan-Clinical Attribute and Treatment. And this is a Jamaican study, and it's a 15-year retrospective study. And of course, there's a unique case report. Next slide, please. The unique case report. Yeah, go ahead. Yeah. So I'll say that juvenile periodontitis is an outdated terminology and must be discontinued despite the call for the condition to be called aggressive periodontitis. It is important that we retain the word juvenile periodontitis, but ensure that these conditions stand out
from the aggressive bone loss seen in HIV/AIDS patients and other immunologically related aggressive bone loss. And so we're looking at non-immunological. So why non-immunological juvenile periodontitis as a new terminology? A lot of conditions have caused accelerated and aggressive bone destruction in the periodontium. And then HIV/AIDS is one of these conditions, and this accelerated aggressive bone loss can actually occur at the juvenile stage of life. It is for this reason that we now advocate for the previously termed juvenile periodontitis to be called the non-immune deficiency juvenile periodontitis. It is so important that the word juvenile be still present. Now, there is a diagnostic dilemma against the differential diagnosis and poor oral periodontitis. In other words, adult periodontitis, and there is also the accelerated bone loss that you see in patients who have Down syndrome, cyclic neutropenia, and Papillon-Lavure syndrome. So to rule out cyclic neutropenia, you need to do periodic CBC with emphasis on neutrophil counts. And once things are normal, you rule out cyclic neutropenia. And then in Jamaica, before we treat juvenile periodontitis patients, microbiology is important. So we do microbiology for culture and sensitivity tests, and we take swab from the periodontal pocket. And the advantage of this does not need to be overemphasized. You'll be able to find out which bacteria is causing the condition and which antibiotics is going to be used to eradicate the bacteria. And this is a collection of microbes that have been seen in different patients. And you can see we have even isolated Pseudomonas. Yes, of course, AA is there, and we've isolated Klebsiella oxytoca. And of course, the various antibiotics that are used to eradicate them actually did the work after confirming from post-treatment culture and sensitivity. So I told you how to rule out cyclic neutropenia. And then, of course, the further significance of culture and sensitivity is post-treatment. What I'm saying about post-treatment is that when you do the surgery and you have also given the patient the appropriate antibacterial microbiological agent, you can now proceed and do a post-treatment culture and sensitivity. And of course, the advantages of advanced imaging is there because it tells you where and how to do your bone grafting, and it tells you the hopeless teeth that you have to remove. And in Jamaica, we have done implant for patients with juvenile periodontitis. Once the post-treatment culture and sensitivity tells us that the microbe has been eradicated. So extraction and dental implant therapy is a treatment, and removable prosthesis is also a treatment, but we prefer flexible denture other than acrylic denture. And in conclusion, regardless of the severity, extraction must be the last option of treatment and of management. And when there is extraction, you must do socket grafting. And if the patient can afford, implant therapy. Also, we want to stress that acrylic dentures should be discontinued in patients with juvenile periodontitis and flexible dentures should be used. The name juvenile periodontitis must be changed to non-immune deficiency juvenile periodontitis. Thank you.
Thank you very much, sir. The paper was non-immunodeficiency juvenile periodontitis, pan clinical attributes and treatments, the Jamaican study. The presenter talked about the attributes of the pathology he was discussing. He justified the need for a change of terminology. He discussed the diagnostic dilemma with chronic periodontitis and why emphasized the importance of hematological investigations in differential diagnosis. He highlighted the role of microbiology in treatment and the role of advanced imaging as a guide to surgical rehabilitation. He highlighted something that I'm particularly concerned about, the use of flexible dentures and acrylic, but I'm constrained by my position to have no comments about that. Thank you.
Thank you. Question, comments for the, yes? Can you just identify yourself and ask your question? Who is the other person? Okay. Dr. Vimpe.
Good morning, everyone. Thank you for your presentation. That's on juvenile immuno micro, or what did you call it now? The name is very confusing. So I want to find out what was the commonest bacteria that you find in your study, because you didn't mention this. And is it similar to what we have in normal periodontitis? Okay. Yes, you can go ahead and respond.
Yes.
Thank you very much. When we were in school, we heard about AA and capnocytophagia. But what we have found out is that the organisms are not consistent and they are variable depending on the age of the pocket. And in Jamaica, we have identified more Enterobacters and Klebsiella oxytoca than even AA and capnocytophagia. So what we are documenting there microbiologically is different from what is being documented. But I want to say to you that most centers, they manage juvenile periodontitis without diligent microbiological investigations. Thank you.
Okay. Thank you. Please, just information. As you're asking the question, your name is important, your institution, and the year you graduated. Very important. So, Dr. Adebinkwe Ibitayo, you have the floor.
My name is Dr. Adebinkwe Ibitayo. I graduated in the year 2000, Y2K. Okay, so I just wanted to ask, I'm not sure what part of your presentation had to do with pathologic, I don't know what that's called, like the migration of teeth. When they go and thank you, Dean. Thank you. So have you considered, I'm an orthodontist, always like that's afforded to people. Have you considered like integrating that into the therapy for the people that have already had like a lot of issues? Because it's like a snowball effect. where you have teeth that are moved, and then you have a bite that's horrible, and then the movement makes the bite worse, and don't show them even worse. So I just wondered if there's a programming department to help with some of these patients.
Pathologic migrations are usually variable, and depending on the surgery to replace lost bone and how the tooth is stable in terms of mobility, then you can now refer the patient to the orthodontist. Of course, the orthodontist can do a lot. Okay? So there's an omission in the paper that we didn't put orthodontic treatment there. There is a need for orthodontic. Thank you.
Thank you, Dr. Gonzalo. Before we continue next series of present, and we join Dr. Agaku online, let me just say for our leaders that are here. Someone asked a question. Okay, he has a quickly.
Good morning, everyone. Thank you very much, sir, for your presentation. My name is Taiwo Gunjobi. I'm a dental student. So in your presentation, sir, you made mention of the fact that there is juvenile periodontitis and there is adult periodontitis. So I want to ask that, what are the indicators differentiate periodontitis from adult periodontitis? Is it just the age, or are there specific organisms that distinguish them, or what are other criteria? Thank you, sir.
Thank you very much. That's a very good question coming from a dental student. Sometimes it is technical, a little bit tricky to differentiate juvenile periodontitis from adult periodontitis because, for example, juvenile periodontitis can actually show up clinically at the age of 30, right? And a lot of adult periodontitis can also show up. What is going to bring juvenile periodontitis out is that the oral hygiene is usually good. You're not going to find all those calculus and so on and so forth. And but adult periodontitis, you're going to see a lot of plaque, a lot of calculus, and so on, right? So that's it. And then in juvenile periodontitis, there are usually bilateral bone loss in the lower molars, all right, in the same manner. And also, there is involvement of the anterior teeth also. The premolars are usually delayed in involvement in being involved. Okay? Thank you.
Okay. Thank you. Now we want to join Dr. Agaku online. But let me just do a few recognition. It's difficult to say, introduce a person when she has been XXX. But let me just say, former dean, former DVC, former director, Professor Bimi, okay? No, you have said XX, former, but current president of Unibadan, Dental Alumni Association, Global. Thank you, ma'am. The rapporteur said, a Sweet 16 is here. Professor Obafunke Denloye, HOD, Child Health. Dr. Adebimpe Ibitayo is here also, 2000 set. Professor Folake Lawa, HOD, Community Dentistry and Perio. And of course, my friend, he has presented, my friend, my brother, and my enemy, Dr. Bode Ogunsalu. So we join, are we online? Okay. Okay. Dr. Agaku.
Yes, sir.
Good day.
Hello,
So
sir.
you're online.
Can I proceed?
Yeah, you can. Thank you.
Okay, okay, awesome. Thank you. All right. Thank you, everybody, for giving me this opportunity to speak. I will be talking about guardrails for AI research. We all know we live in the AI bubble, and there's a lot of hype about AI and research. So how then do we ensure that the research we do is still valid? And so I'll be talking about prioritizing accuracy in an era of speed. So how do we do that? Obviously, AI has its benefits. AI has the agility and a lot of benefits which we can't just deny. Well, the way we can achieve accuracy in an era of speed is to take the best that AI has to offer and then complement that with rules-based engineering. So that means that we use AI for what it does very well, but every other thing where there's risk for error, we then implement with algorithms that are based on rules. So our framework in our engineering processes is that AI cannot be allowed to touch data. So that means that anything that has to do with computation or analysis or anything that has to do with any kind of data cannot be touched by AI. And that's the way that we are able to achieve speed as well as accuracy. That first of all recognizes that we must acknowledge the kinds of things that AI does very well and the kind of things that AI struggles with. So we classify all type of work into 3 tiers. Tier 1 is, things that AI will always get right. So you say, take this text, this small text and make it big, or take this big text and make it small. AI will always get that right because that's what it's designed to excel at. And then we have tier 2, which is good enough work. Here we're talking about pattern recognition or taking, for example, structured text and making it unstructured or vice versa. It will do that very well enough. But then we talk about tier 3 work, which is where AI starts to struggle. This is where we're talking about where we need accuracy, 100% accuracy, 100% of the time. And so AI might struggle with that. And so when designing our engineering systems, we have to look at those gradation of work and say, where can we integrate AI and where can we absolutely not integrate it into our workflow? And that's what we've done at Chi-Squares. I'm going to show you a quick demo of how that works in 2 minutes, show how we've been able to adopt the best that AI has to offer while, and ensuring that we implement accuracy in all that regard. So let me head over to the app and show you quickly how we have done that in our engineering flows. So let's say you want to write a manuscript. You've never written a manuscript before, and you want to write one now. You come to data analysis and you upload your data sets. So for example, let me pull up a data set. Let's say my research question is the relationship between oral periodontal disease and diabetes. So let me just call this diabetes. That's my research question. Or how does periodontal disease influence diabetes? So I'm going to upload the data set quickly. This is my data set here. The platform reads that, like I said earlier, everything that has to do with analysis or data cannot be interfaced with AI. I can record my variables as needed. Now, let's say I have not written a manuscript before, like I said. I can come to my analysis wizard and click on analysis suggester. I can upload my variables that I care about. Again, up to this point, no AI used based on our risk-based algorithm. That's my primary outcome, which is diabetes as detected in the lab. I may also have a secondary outcome, for example, maybe self-reported diabetes, which is this variable here, and that's a categorical variable. My main predictor is periodontal disease, which is captured here as a binary variable. And then lastly, I have to select some demographic variables. Let's say my age, my sex variable, let me add a couple, and maybe race, ethnicity. And so once you select these variables, then you can then click on suggest analysis. There are few places in the world that have as many rules as statistics and epidemiology. There's a rule for everything. And wherever we work in an environment where there are a lot of rules, that is a fertile ground for automation. So not all automation involves AI. And that's what we've taken advantage of here. So once you click on suggest analysis, the platform takes that data you've supplied and suggests tables for you. So here, for example, it says your manuscript should have 4 tables: table 1, table 2, table 3, table 4. So that lack of knowledge, if you've never written a manuscript, should not be a barrier to you doing good science. And all you have to do is simply come and just click on run this analysis for any particular suggested analysis. So when you click on run this analysis, the platform takes that data, it analyzes it for you, it writes it out for you. And so that again, that overcomes that barrier to knowledge. So now it has done the analysis, it has formatted a table. For every analysis done, you have all right, now, at what point then do we integrate AI to make it fast? So now we'll use rules-based algorithms to expedite the analysis. Well, we can then use AI for what it does best, which is summarizing text and generating text with large language models. So now if I wanted to write up my analysis or write up my manuscript, all I do is push my results into my manuscript. So I can click on actions here and click on push results. I can generate a new manuscript on the fly. Let's say I'll call that relationship between diabetes, between periodontal disease and diabetes. I can suggest an aim. And again, these are areas where we use AI for things that are not really high risk. So AI, we use AI to suggest aims for your analysis. So here, AI has suggested some aims based on the context, which is our title. So I can select some of the aims that AI has suggested, and I can then start writing. This is the manuscript we just generated, and I can then push my results to that manuscript. And so now that we've pushed, I can go and view that document and then consider my manuscript. So this kind of workflow makes it easy for us to be able to take the best that AI has to offer us, which is its ability to generate text. And we use that a lot in parts like the introduction. If you want to generate your introduction, well, you can use AI. You can say, oh, well, AI, or let me just provide my inputs for then AI to take and paraphrase, right? We think those kinds of usage for AI are very low risk because they don't interface with data. They don't interface with any kind of data, whether it's your analytical data sets or your bibliographic data. And in that way, you can write a manuscript really fast. Like I said earlier, things like bibliographic data in terms of references, we also think that that's high risk. And so AI cannot be used there. And so in our workflow, the way we reimagine the scientific process is just thinking very intentionally about the whole process and thinking which steps are high risk, where we cannot use AI, and which parts are really low risk, where we can use AI. And so that is our approach to engineering the workflow. And I'll be happy to take questions. I know this is a very long time, so we can definitely have a session in the future to have a more detailed dive in. But for now, this will just provide a very high level overview of how we've thought about the workflow and partition it into low risk tasks and those that are high risk. Thank you very much for the time.
Thank you, Dr. Agako. You'll be able to answer some questions?
Oh, definitely, yes.
Okay, good.
So thank you very much. The presenter presented guardrails for AI research, prioritizing accuracy in an era of speed. He emphasized that we can use what AI is best at and keep data out of AI for the integrity of our work. And he also emphasized that there are other algorithms outside of AI that can simplify our work. And he categorized tasks into 3 tiers, tier 3, tier 2, tier 1 tasks. And he emphasized that AI would be appropriate for tier 3 and to some extent tier 2 tasks. And he emphasized that AI is very good at recognizing patterns. Now he also, because of some of the properties of AI, he advocated for that if you're going to use AI as a beginner in writing manuscripts, you can use it for generating your introductions by imputing your data and results. AI can generate an introduction for you. Thank you very much.
Thank you, Dr. Kushika. Don't know if we have comments, questions before we go. Yes, Dr. Olakunle Johnson. Microphone.
Thank you. Dr. Agako, thank you very much for your presentation. But my comment is, when I finished secondary school, I was given admission to study engineering. And I told my father, no, I won't do engineering. I want to do medicine. But I now found out that engineering is also in medicine. So now, my comment is that I will appreciate if the school, the dental school, can incorporate into the curriculum something like AI, so that our students, as they are being graduated, they can be prepared for the outside world. Because everything is now going engineering, medicine, everything is going that way. So if we can find a means of incorporating part of this engineering into our curriculum, I think it will go a long way. And this, the alumni can also assist in this regard, so that engineering, so to say, AI and co, can be incorporated into the curriculum in training our students. Thank you.
Thank you. Any other comment?
Thank you very much, sir. All protocol duly observed. Thank you, Dr. Agaku, for the presentation. Dr. Agaku happened to be my very close pal when we were in school.
Introduce yourself.
I'm Dr. Bezo De Matthew, 2009 graduating sets. I was privileged to be part of the cohort of people that actually tested this device. I can attest to its efficiency and accuracy and the speed. But in terms of being fast in the era of AI, I have a little bit of clarification. It's concerning the price of this particular software. How economic friendly is this? If you are trying to be fast, we should always watch our pocket also, especially in this part of the world. Dr. Agaku is up there in Boston. We are here in Africa. How friendly is it to us in this part of the world in terms of the financial implication? Thank you very much once again, Dr. Agaku, for your presentation.
Thank you. Should I respond or let take all the questions at once?
You can respond.
Okay. Well, we've tried to provide some massive discounts to people in low and middle income countries, but we can surely provide a very, very, very special package for the College of Medicine that is like super accessible. I mean, that way, at least that shows that we are supporting the cause of college. We can do, but we've also already tried to provide discounts for low and middle income countries. But in addition to that, we can provide a special package for the college.
So I think, we can, I don't think there are questions or comments. So Dr. Israel Agaku, thank you very much. We always appreciate your interest in your institution. And we know that when we call you again, you'll be ready to give a presentation. Thank you very much. Can we appreciate Dr. Israel Agaku? We are highly privileged.
Thank you very much.
Thank you. We are highly privileged this morning because the president, the global president of the International College of Dentists is around in this auditorium. Can we just appreciate him? We know that the International College of Dentists, they are really, part and parcel of this particular celebration. So we want to welcome and the president with his wife and Dr. Andoy and Mrs. Andoy. Can we just appreciate them? Let's appreciate them. You are welcome, sir and ma. You are welcome. You are welcome. Thank you very much, sir and ma. You can have your seat, sir. Yeah. Also, I want to recognize my boss. It's in the university system, an employer can be an employee. Ex this, ex that, ex dean, ex sub-dean, ex president of MD Khan, everything. My trainer and my teacher, Professor Juwon Aruchiba. And one of an alumnus is also here. I think 2 years after, I think it was 2 years my junior in school. Dr. Fatosi, are you big now? Dr. Fatosi, where is he? You are there. Dr. Kinde Fatosi. Thank you. So we go to the next presentation. We want to thank you for your patience. It has been a very interesting session. The next presentation will be delivered by Professor G.A. Oke. We have about 7 or 8 authors here. And the topic is oral healthcare delivery to the underserved communities. The role of community dentistry units, University of Ibadan, University College, Hospital Ibadan, Nigeria. Let's welcome Professor Gwemisola Oke.
Good morning, Chair. Good morning, everybody. Oral health care delivery to the underserved communities, the role of community dentistry units of the UCH and UI. Permit me to recognize the Deputy Vice Chancellor Academic, Professor Arutiba, and also to make a declaration that this topic, these slides, and everything about this has been prepared by Professor Lawal, and she only asked me to present so that I put my voice to it. But it's a lesson, and I think the lesson about this is about sustainability. Sustainability, this program that we're talking about commenced in 1987. And indeed, this is the 40th anniversary of our program. And today, you are going to be looking at pictures in which I do not appear. You are going to be looking at the pictures in which Dr. Fatunde does not appear, because everything is running without our being there. And I think that is the story of this whole journey and this presentation. So, next slide. Background: access to oral health care is significant to public health problem in developing countries like Nigeria. And there are ongoing efforts by community dentists to combat this problem. And sparse documentation of the initiatives there's past documentation, and it is aimed at advancing health equity. The methodology, the aim, is to describe our contribution over these 40 years to advancing the cause of oral health in Nigeria and beyond, particularly from our immediate environment. And the methodology is that a number of community activities have been documented here, and some data were extracted and analyzed from our records. Next. And over 15,000 patients have received care at our two primary health care centers established at Idikon and Igora. I am sure this is a major under recording. However, what we can, because I was told that some of our records, we cannot retrieve them, but what we have and what we can lay hands on is 15,000. And you can see when we started what the building, we started very, very low and young, but now you can see on the left-hand side our building at Idikon, and the inner aspect of it is our dental chair in that place. And the first, please go back, the first handmade dental chair designed by my humble self was what we were using at the time, and the duo of Dr. Fatunde and myself will go into the community, and there was really not much at the time, but we improvised, and so today we can, whatever you see now is what we have built on since then. Next. And so pictures of our community activities in front of our Idiko clinic, and you can see an array. Dr. Okweodu is there, Dr. Lawal, of course, and so many others, but I'm not there. So this is Igboora, another place where people have to go, have to be trained, have to have visited and had their posting before they are they can complete their training. Next. So we have seen patients. Next. Evidence of another place that we have recently gone to, which is the Koladaisi Foundation Center, just next to us. It's a primary healthcare center. So we are, and we also have Enyosha. We have others. So we have had almost 2,000 undergraduates and postgraduate students and interns visiting our different centers. Yes. Again, picture show of our community activities, undergraduates, postgraduates, and interns. Yes. Another in class setting and other focus group discussions, postgraduates, students, and interns. Next. Another set of pictures of our outreach to the community. Next. Research projects that have taken place on our grounds, 4, 5, 6, wow, 4, 5, 6 research projects have been supervised and conducted. And then more pictures of researches that have gone on. Results, oral healthcare services provided by our unit included consultations, education, counseling, dental treatment, and referral. Again, more of our outreach pictures. And the treatments included teeth extraction, prophylaxis, atraumatic restorative treatment, fluoride therapy, composite restoration, and facilitating denture fabrication. More pictures of our outreach, more in our dental center. Next. And we have partnership with DOFA. That's Dr. Adejoke Fatunde's NGO organization in the USA, and we're never ever short of supplies. In actual fact, we're a blessing to other units when we begin to share the booty that lands. And for your information, another container has just landed. In conclusion, we thank you all for listening.
Thank you, Ma. She spent about 8 minutes, but permit me to speak pidgin English. They no pon me well. There's something that Ibadan is known for, and this was aptly demonstrated here. And it's something I'm forever grateful for, because I'll probably be dead by now if not for this school. Dr. Lawal, Professor Lawal, my neighbor in Bodija, gave the honor to the teacher. The same way I'm here because I had to honor one of my teachers too. So that's something that Ibadan is noted for and is very commendable. Professor Oke showed us evidence of the great work they've been doing since, for 40 years now. They've been doing things for 40 years. They now have about 4 centers. In addition to Idiko and Igbora, there's Kolada, Esi, and Iliosa. Then they've had, well, she also admitted that it was an understatement, about 15,000. That figure will be closer to 100,000 people that have been treated, because even during our own posting itself, we will treat close to 50 people per posting. And very importantly, they've had about 456 research projects coming out of this work. And we want to thank the NGO from Texas that they are collaborating with. Thank you very much, man.
So I don't know if we have questions for Professor Oke and our team. Comment, okay.
This work to go on. But I was told that there is a container already. So I think Dr. Fatude, he can continue. But all the same, I think it's something that we need to put money into, because we are actually helping those who can never thought they can have access to dental treatment. And this is something that is, I think we should put money into, so that it will be continuous, so that it's something and they will develop it more. But I know that I will talk to my mommy, but I learned that she has the capacity and capability to continue. Thank you.
Professor Ajayi.
Thank you very much, Ma, for presenting. Something just came to my mind, and I said I was going to ask for the challenges that you may be facing there now. And Dr. Johnson mentioned the issue of financing. The first thing that came to my mind was, if we could be experiencing the incessant power failure here, and power has been a problem until recently, what's going on at Idikon especially? Thank you very much.
Thank you very much, Ma. Thank you for the question, Ma. at IDICO, we don't rely on public electricity supply. What we use is the generator, and that's what we've been using since inception. We operate revolving fund until recently that we need to pull our money into the TSA and College of Medicine revolving fund. So when we make money, we take out of that money to buy fuel, operate our generator. NEPA, no electrical. We yes. So it wasn't a. We've been making use of our generator, and the University College Hospital just supplied a new generator. So we are using that, and we'll be grateful if we have solar. Thank you, ma. So, no, I have to first say differently so that now I've gone down, we will be most grateful. And we know that in the next few months, we'll get the solar from us. Thank you.
Okay. Professor Okupong, she's there. Okay.
Yeah, thank you very much. Definitely what you do here in Ibadan is excellent. Just one or two things that I'm curious about, and that is about the integration. So far, it seems as if you're running a parallel structure that isn't integrated into the primary health care. I would like to know not only the integration wherein you have a system that says primary health care is delivering oral health, but integration in the way that the ministry itself is also taking over its operation, including the supervision, its annual operational plan, so that money is also coming from the primary health care system to support and own its own system rather than the parallel. Congratulations for your success story. Don't worry, Ife, which is the powerhouse, will come to tell a better story. Our community program is really great. Okay, thank you.
Okay. Any other comments or questions? Let's appreciate Professor Oken and the team. We want to go to the next presentation. So something tells me I might not be paid my salary at the end of the month because I didn't introduce my boss very well. You know, I said from employer to employee. Professor J.T. Arotiba, he was a member of the council of the University of Ibadan, but now DVC academics. So let's happy. The more you clap, the more they pay me my salary. So clap. So we can go to the next presentation. And this one is from the Department of Oral and Maxillofacial Surgery. And the topic is perspectives of students on the standard of training at the Ibadan Dental School, a cross-sectional survey of clinical students and recent graduates. Dr. A.A. Salami will give the presentation.
Good morning, teachers, colleagues. My name is Salami Afiz. I'll be presenting the perspectives on the standard of clinical training at the Unibadan Dental School, a question survey of clinical students and recent graduates. Clinical training is integral to dental education, and it bridges the gap between theoretical knowledge and practical experiences, which is essential for life, safe and patient care. The quality and adequacy of clinical exposure directly influences the graduate preparedness for professional practice and lifelong learning. So since 1975, the dental school has been training high-quality dental graduates who are dictating the pace of dental practice globally. And a continuous evaluation of this clinical training is very important for it to maintain that leadership role it has always had since 1975. And this study, therefore, evaluates the perspectives of our students and recent graduates on the level of training they receive at the Unibadan Dental School. So we did a cross-sectional study after obtaining an ethical clearance from UIUCH ethical committee, and we surveyed 600 level students and recent graduates, as well as the 500 level students, who we think they are the cohorts who have actually received the clinical training during the dental school training. So the 35-item Likert scale questionnaire was distributed via Google form, and we obtained analysis using descriptive analysis on the SPSS version 28, and also a thematic analysis was conducted for the open-ended questions. So the mean perception score were calculated for 8 dental disciplines, including oral maxillary surgery, oral pathology, endodontics, restorative dentistry, prosthetics, and also oral pathology and oral medicine, and also orthodontics. So, and then across 5 different domains, which are hands-on experience doing their posting, supervision by their teachers, teaching structures, confidence post-rotation, and also resource adequacy. So we did the bar charts to visualize the mean evaluation score and also the frequency of challenges. So we surveyed 100, we sent our questionnaire to 100 participants, but we received 60 responses. And most of these responses were males, 58.3%, age between 24 and 28 years, and also 56.7% of these respondents were in final year, while 23.3% were recent graduates who are just doing house job, who graduated in the last 12 months. So the result, this also just summarizing the demographic analysis or characteristics of the participants. So on the perceived standard of clinical training by discipline, the mean perception score was evaluated based on the 5 independent domains I actually discussed at the method session. And oral pathology discipline of the University of Unibadan Dental School actually received the highest overall mean perception score by the students, which is 4.0 out of 5, reflecting the integration of clinical and histopathological teaching, as well as the consistent consultant availability, as said by the respondents. And also the oral maxillary surgery and restorative dentistry were also highly rated by these students, who cited practical opportunities, teaching structures, and also mentorship as key benefits in these 2 disciplines. However, unfortunately, from our analysis, we had community dentistry having the lowest overall perception rank among the 8 evaluated disciplines, with 3.2 out of 5, particularly scoring low in hands-on experience and resource adequacy, which emphasizes the need for funding of the department or discipline of community dentistry in Unibadan Dental School. And here this gives us the mean perception score, like I described earlier. So based on perception, 66.7% of the students believed the training has adequately prepared them for independence practice against all odds. And the identified strengths of the training in the dental school were basically high clinical exposure, patient diversity, faculty expertise, and simulation opportunities, especially the use of the phantom head lab and also the surgical clinical training lab that we now have. On the other hand, they faulted limited access to modern equipment, inadequate hands-on experience, overcrowded clinics, and poor faculty-student interaction as the major barriers to clinical training, which emphasizes the need to actually expand the dental school as soon as possible. So addressing these challenges, the respondent recommended, in their own view, an increase in dental rotation time, upgrade to equipment, reduction in the number of students within rotations, supervision, and curriculum review for more effective Ibadan Dental School training. My conclusion, therefore, is why Ibadan Dental School is perceived as a leader in dental education, strategic improvement in infrastructure, clinical exposure, and supervision are required to enhance graduate readiness and maintain Ibadan excellence in dental training. Thank you.
Thank you very much. The topic was perspectives of students on the standard of training at the Ibadan Dental School, a cross-sectional survey of clinical students and recent graduates. The importance of clinical training was highlighted. The study was justified. A mention was made of ethical approval, but study participants were 500 and 600 level students. There were no recent graduates in the body of the presentation. No, he didn't. He just said 500, 600. At the beginning, you understand what I'm saying? In the body, that was an oversight. Okay. So, the thematic analysis for the open-ended questions was made, but there was nothing said about how your minimum sample was determined. So 5 domains were assessed, including hands-on, whatever the students perceived of the abilities of their trainers and the facilities available for their training. The response rate was quite not encouraging. It was a 60% response rate. And, well, I don't know if those specialties should have been named. But, well, oral pathology outdid everybody. Concerning some of the questions you raised, are you willing to become a lecturer? Are you willing to forgo JAPA opportunity and stay here? That's where the real problem is. Thank you.
Thank you, Dr. Kushika. It's good to get perspective from students, but you know, one thing about student research is that when they see tough departments, you know, their responses can be biased at times. That is the truth. But let's go to the questions and comments. Dr. Bimpe, she's there. Dr. Ebitayo.
Hi, it's Dr. Ebitayo again. I just wanted to say something from the perspective of somebody that jackpot, okay? Yeah, out of necessity. When you guys leave the country, it's very rare that you are ever lacking. You're one of the best. I was the best in my class. Out of the fact that, seriously, I'm not saying that just to boast, though. And I wasn't even the best out of my graduating class. It's just that there's nothing that they ask you there that you haven't heard. You think is useless information. But when they ask you about priapism, you're the only person that knows it. When they ask you about BRCA1 and whatever genes, you're the only person that knows it. But at the time when you're learning it, you feel like, I'm a dentist. What is all this? This nonsense is nonsense. It's not nonsense. So there's no knowledge that's lost. That's just part of it. So I guess what I'm trying to say is that whatever it is that you think you're gaining out of this program, you may not appreciate it right now. But there's none of my colleagues that I know that went anywhere else. It doesn't have US, UK, everywhere that didn't succeed. And they always look like, you guys, you knew these things. It's not like we knew it. It's just that University of Ibadan is like you passed through the eye of the needle. You went through fire. There's nowhere else you will go that you won't succeed, though. That's just my own. I don't have a question. I'm just trying to tell the students that there's nowhere you go that you're not going to excel. Thank you.
Thank you, Dr. Buta. Yes? No, Dr. Fatunde first.
Thank you very much. I very much want to commend the presenter. There is nothing, no matter how good we are, getting a feedback on our performance is so vital, because that is how we know how to improve. So the fact that you brought these perceptions to us is a lot of instruction for the faculty, for the school itself, for the alumni to go back to the drawing board and say, okay, how do we address these perceptions? How can we improve clinical training? Because that is the purpose of the school. I want to also commend Dr. Binkwe for her comments. I remember when we started out, we did almost every posting like medical students except O&G. That was the only specialty that we didn't get full exposure. We got lectures. We just didn't go into the clinics or to the delivery room. And at that time, it was frustrating somewhat, because it was like, I'm in dental school, I'm learning so much of medicine. But guess how it came out positive? When my son got into medical school and we start talking another way, Mom, how did you know all this? I said, I pretty much trained as a medical student except for O&G. And so every now and then he'll bring things and, we'll talk about it. Of course, my knowledge was not as good as his, but it was comforting for me to know that he could discuss with me. And every now and then I'll get a call in the middle of the night. Oh, I'm studying this and I'm kind of stuck. And I'll say, oh, this is what my teacher told me. I said, really? So no knowledge is wasted, truly. Also, I really appreciate the fact that he did that. This survey was probably done before accreditation. And we all know the scare about that. We all know how bad the equipments are. I'm hoping that in the next 1 to 2 years, at least the effect of the new equipment can be felt. That's still not all that we need to do. There's a whole lot. He really packed a lot into that survey, and I'm imploring all faculty members, please take his presentation and really look through so we can see how to address the needs of the students and residents that are going through this institution. There is always room to improve. There's always room to learn. And part of our service is making things better for everybody. Thank you.
Thank you, ma'am. Oh. Okay.
Thank you. The training we are having in Ibadan is commendable. I think I've met some of our teachers and I've told them my experience. When I was in 4th year, 400 level, I went with Nigeria dental students. We went to Abuja, we drove. In the vehicle, I have 600 level from Benin. I have 600 level from Ife. And when we were discussing, and I wasn't too much a serious student, and I was moving stuff. At the stage, they said, are you house officer or final year? I said I was 400 level. And they were highly impressed that how do I know all this? And when I was last year or so, I was talking with Professor Fashola. They told me they have changed the curriculum. In our days, 4th year, we come in. After the 2A, the phantom head, we go to the clinics. We are having lectures, and we are in the clinics. The house officers are the one more or less training we that are in 400 level. The consultant, the residents are training the final year student. So we learn a lot. By the time we go back to do medicine and surgery, we come back to final year. We just master everything. But he told me that they've changed the curriculum. That's number one. And the first job I got after NYSC, the condition was Ibadan graduate. Ibadan graduate. And I walked in, and they said, you are from Ibadan. No interview. They asked me immediately, how much do you want to be paid? So I don't know how you're going to do it. You get? Then number two, like, Doctor, don't mind me, I call her Bingpe. What she has said is true. There is hardly anybody from Ibadan that will write the board exam, that will not pass. And I'm saying in the US, in the UK, in Canada. In fact, there are some students that just got to Canada. At least 4 or 5 of them are already doing their program in the US already. So that means the training we are having is very good. But like Dr. Salami pointed out, and I'll be saying it in our alumni, that the faculty and the students should interact more. In our own days, Dr. Fashola will talk about soccer, we talk about England team, we talk, that helps the relationship. So I think we should do more of that. And like I was saying earlier concerning capacity and capability of Dr. Fatude concerning the community health. And remember in our own days, we want to go to outside, to a deacon, they say, no gas, what's it called? The car is not working. The van is not working. And I think that is one thing that is affecting the community health, that relationship, that feedback is what we need to be getting every time. Why the students, the lecturers are here because of the students. So they can tell us with that, look, we need you guys to do this, to improve on this, to do this. So that way we're going to have an holistic preparation for the students as they go outside. But I must say, this is the center of excellence. And let us keep it on. And the alumni is ready. In fact, the alumni is saying that why do you have to have faculty of dentistry? That you guys should be preparing for college of dentistry. Abi my mommy, that we should be preparing for college of dentistry. I don't see the reason where endodontists will still be under restorative. Endodontist department should be standing by alone. So I want us to be thinking along this line that we will have to be college of dentistry. So the alumni is ready to support in every means to make sure that we achieve this. Thank you very much.
Yes, thank you. Dr. Ibiyemi.
Thank you. I'm Dr. Ibiemi Oduemi, 2004 class. Yes, I want to commend the presenter, but I have a question. Was ortho and pedo disciplines considered? I would love to hear the results. Yes, because even for residency, to get residents coming to do pedo has been a tall order. So I just want to know from the student perspective in that area. Thank you.
Dr. Salami.
Thank you very much, man. We actually got evaluation from the orthodontic department, but we did not get from pediatric dentistry department. I mean, we look at disciplines, so there was an error in our recruitment evaluation. Thank you. We are sorry about that.
Yes. Any other comments? Okay, Professor Lawal.
Yes, sir. Thank you very much, sir. I'm Folake Lawal.
I graduated in 2003. And my question, thank you so much, Dr. Salami, is one of our products. And I must commend his ability to be able to carry out that study. In fact, it shows that community dentistry has impacted something on him. Yeah, sincerely, during our blog posting, we take them through the rigors of research. And we take them through the different methodologies. And now he's talking about thematic analysis. It is a plus. In addition, I would like to thank the alumni for their support. And I believe now that his research or their research has showed that community dentistry was rated lowest because of lack of resources. So I'll believe now that one of the questions I'll ask him is, how will he disseminate to the faculty apart from here, so that these things, his findings can be tabled. It has to be tabled so that whenever they are sharing any formula, the community dentistry can take more. Yes, so that we can be rated higher. And well, yes, thank you so much. And apart from that, how will you assess the perspective? You've done a survey, but the main thing, which is the perspective, that will explain why they did it, because you know what you use has constrained them to be able to voice out, and then you've actually identified something else as part of the limitation of the study, not including peril. I think you should go ahead and conduct a larger study and look at the qualitative aspects. Probably they'll be able to do that. They will be able to know more. We conduct feedbacks after our own blog postings, but it is community dentistry. Though we have negative feedbacks, and we've been using that to improve. One of those negative feedback is that we are too strict. Our head must be 8 o'clock. If you come late, you'll be outside. So they rated, during the feedback, they told us that they don't like being, doing all the other postings. Their teachers were not as strict as we were, but we tell them that 1 minute, 1 second can cost the patient his or her life. So they do not like that. But we will still call. But they've been giving us different feedbacks, and we'll be using that to improve on our teachings. And apart from that, when we fight during our meetings, it's based on their feedback. And I must thank Dr. Salami for that good job.
Thank you. Very interesting comments. As I said earlier on, one of the problems with students and research, bias. Usually, if you are a department that is very strict, you may not, really get something, something good. But I think if this research is done maybe in a year's time, things, will be better because the alumni, they have really done well in terms of equipment and materials. Let's, appreciate the alumni. We want to move on. And
one more reaction.
One more. Oh, okay.
My name is Comfort Adekoya Shofora, a professor of pediatric dentistry. I'm reacting to Dr. Ibiyemi's year of graduation is 1983. So I just want to react to his question. You see, most of the Nigerian dental school, they always have ortho and pedo together. In Ife, it seems as if we are tired of the marriage between ortho and pedo, and we are planning to separate. If we are standing alone, that study, they will not omit pedo from the study because they will go department by department, and then we will know how we are progressing, and auto too, we know how they are progressing. So I'm going back to Ife and reinforce that idea that auto and pedo should separate and then run a different department. Thank you, Dr. Ibiemi, for bringing that.
Thank you, Dr. Professor Shofobora. I think Benin is separate now. Benin has, permit me if I'm wrong, I think Benin has separate, yes. Yes. Even they have Perio. Perio is a department in Benin. We are getting a lot of things. Time, you are the one answering questions. Let's move on. We have a paper from Enugu, Nigeria. Oral health and human rights, bridging the equity gap in global health policy. Dr. Okereke is presenting that paper.
Good morning, my teachers and my trainers. My name is Dr. Okereke Promise, and I will be presenting on oral health and human rights, bridging the equity gap in global health policy. So here are my outline, and here are my list of abbreviations. So as a form of introduction, oral health we know is essential to well-being. However, it is mostly neglected in policy and rights and human rights paradigms. According to the World Health Organization, we have about 3.5 billion people affected globally by oral diseases. And a higher proportion of these population, a higher number is seen in the marginalized population. So why do we have to talk about human rights in correlation to oral health? We know that the right to health, we believe that right to health should also include oral health. And oral health is often excluded from the universal health coverage, which brings about its neglect, thereby creating a systemic human rights issues. So the objective of our study was to explore the intersection of oral health and human rights. And by applying the AAAQ framework, which is availability, accessibility, acceptability, and quality. And we want to assess the barriers and further identify the systemic obligations towards in regards to oral health and human rights. So we conducted a qualitative conceptual policy analysis from international legal documents like the Universal Declaration of Human Rights, the Convention on Rights to the Child, and World Health Policies, and over 80 peer-reviewed articles. And we applied the AQQ framework and other human rights principles. So we used this framework whereby we looked at the international human rights, and bringing in the AAAQ framework, we now come down to the oral health system, looking at the policies and the services as it relates to oral health. So we found out that oral health is underrepresented in rights-based frameworks. And also human rights instruments rarely mention oral health explicitly. In most documents that we see, you see that oral health, they just put all together overall health without explaining oral health. Now, few universal health coverage systems cover preventive or population-wide oral health care. So it's mostly preventive. No advanced oral health care has been put in place. Another key finding was we found that there is systemic barriers, thereby leading to human rights violations, which we saw as a form of financial exclusion, geographical inaccessibility, because from high income and low income geographic zones, there are different levels of inaccessibility. We found that there is discrimination based on race, gender, disability, minority groups, and the migrants. And institutional neglect was found also in prisons, elderly people, and the refugee settings. So we looked at the structural barriers to oral health, which spanned across financial,
geographical, cultural, and institutional dimensions. And when we applied the triple AQ framework, we saw that there is shortage and uneven distribution of oral health care providers and facilities. We also saw that there is high cost of dental care, which is in form of lack of insurance coverage and transportation difficulties. In terms of acceptability, we saw that there is discrimination based on socioeconomic status, ethnicity, age, disability, and so on and so forth. Now, we saw that there are substandard and unsafe treatment in situations whereby most facilities just provide extraction. And when RCT could be done or other advanced care, but they would go for the lowest and the ones that is at subpar to the condition. So, however, we saw that there has been recent recognition in terms of the World Health Assembly Resolution 74.5 in 2021, and there is ongoing actions in terms of World Health Organization Action Plan. And we also we saw that there is implementation gap is still persistent. So we are looking forward to the strategies in terms of improving access through basic oral health care, mid-level providers, and and so on and so forth. Also, community participation, just as we have heard in by other presenters, like what is happening in the community primary oral health care. So we are talking about co-creation of programs with the communities, including indigenous knowledge and inclusive practices. And also for the marginalized and the refugee camps, refugee groups, it should also be looked into. And then cross-sector partnership. The role of government, they should be the duty bearers of health rights and respect and regulate private providers and invest in services and education. Also the role of advocacy and policy. Now we are looking forward to future research in the sense that there should be, that we couldn't see that we are disaggregated data on some of the parameters, socio-demographic parameters. And we need more comparisons between countries with oral health and those without oral health laws. And also look forward to community-led intervention in marginalized groups. Also study corporate influence on oral health. So oral health, in conclusion, is equal to fundamental human rights. It should not be treated as a privilege. It is a necessity. And there is current inequities which further exacerbate the systemic human rights violations. We should shift from charity to ensuring that justice is done towards oral health actions. So government practitioners and researchers should come in together and bring about a definite change. These are my references.
Thank you very much. From the chairman, I've been instructed to appeal to us to limit background noise. Thank you. From me, in my job as the summarizer, Dr. Okereke has tried to tell us about oral health and human rights, bridging the equity gap in global health policy. I have a question before was this a systematic review? An integrative review? Well, I knew it was a review, but the methodology is, as he has told me now, an integrative review. So he has gotten different evidence and integrated everything together. That would have been better said during the presentation. It would have aided understanding. He has justified why oral health is a right. He has shown that it's basically not well represented in most international documents now. And he has advocated for more inclusiveness of oral health in future policies and advocacy for oral health. Thank you.
Thank you, Dr. Kushika. I don't know if we have comments on Dr. Koreke's paper. Comments? before we go to the last presentation. Dr. Johnson.
Thank you very much. Thank you, Dr. Okereke. I believe most of our discussion today centers on how oral health, dentistry will come much more to the limelight. And this is something that we need to do. So it is the job of every one of us. Thank God today we have our Deputy Vice Chancellor Academic in our midst. You know, that is telling you how far dentistry is going. I remember that when we came in across to the clinical school, even when we get admission, I wouldn't know how my mommy felt when they came in 1975. The dental student at that time, they are like, oh, second rated. But we found out it wasn't like that. Okay? And I believe it is getting better. But it is each and every one of us that need to make sure that dentistry is out there. If we have our people in politics, you are the one that will write the laws, the rules, am I right? And the regulation. Remember to put oral health. Okay? I know a friend of mine in Lut, as a CFP, he makes sure that every year he does something to the dental center. Okay? I know my deputy vice chancellor is here. I know he's going to make sure that more money comes. Am I right, sir? To dentistry. Okay? So once we begin to do this, okay, and I believe if they write the policy very well, each the local government council, I think they are divided into districts. You know, they are supposed to have a dental clinic. Okay? If you have a dental clinic, so in a local government, if you have 3 dental clinics, again, there are 3 dentists working there, dental assistant there, again, and multiply that, I think we have 7 and something, maybe 4 local government. So that is where we can start from. Again, once this is done, there are a lot of people out there that needs dental clinic. Just like we are talking about anxiety, again, they won't want to come to the UCH, you know, but if they have it very close to them, but how they go to have it is when we begin to notice it, begin to talk about it, that people know, dentistry. These days, those who are coming in, they are just enjoying the hard work of those people who have done a great deal of sacrifice. Imagine we are celebrating 50 years of dental school. You get? If you want to say about medical school, I think maybe Unilag was the one that started dentistry and medicine at the same time. You get? So this is our own work. You get? In the US, dentistry is even greater than medicine. You get? And that's why I say that all this, and thank God everybody is talking about break it. Orthodontist stay by himself. Endo stay. Periodontist stay. So that people, even the students, will be very, they will be exposed to all these different departments, and they will be saying, you know how to do perio. It's not when you bring everything under preventive dentistry. You get? So we have to do the job. And when we start doing the job, our people are in politics, they say it out there, and find that all these things, they'll make it a human right. Thank you.
Thank you, Dr. Johnson. Any other comment or question? Yes.
Thank you, everybody, and we really appreciate your time. One thing that I want to impress on all of us is that our mission, yes, we are all good at what we do in the clinics, but our mission is really to be present. You've got to be at the table to be able to influence decisions and policies. We tend to kind of shy back from positions that are not academic. We need to get out there. We need to be in committees. We need to volunteer, to do this, to do that. You are not saying nobody is going to advocate for you. So if anybody is going to advocate for dentistry, it is you and I. Don't expect those in the Ministry of Health to think of dentistry. They just don't think that way. But when we make noise and we don't stop making noise, at some point they're going to have to listen. So we have to take our mission out there. Ministry of Health, governors, local government chairmen, and all of that. We've got to talk to them. Most of them don't even know what dentistry is. We have to educate them. And the value of having community clinics. There are so many primary health care centers, and they don't have any dental unit. Why? What are we doing? Why don't we go to those community dental centers and say, okay, give us a room. We are ready to start dental services. Before you know it, patients will come. If you start it, patients will come. But when we don't talk, nobody knows. So it is the mission of each one of us to advocate for dentistry. Don't expect medicine to advocate for you. Don't expect the Minister of Health to advocate for you. Dentistry has not been in his system, especially if he's not even a medical. He doesn't have to be a medical person to be a permanent secretary in the ministry. So who's going to tell him? It's you and I who's got to take dentistry out of the dental school and into the community, into the government, into the world. It is your job. It is my job. Thank you.
So we go to the last presentation of the day, and it's coming from the Department of Obstetrics and Gynecology. Well, we are friends. And the topic is oral health throughout the decade, science, service, and smiles among HIV positive women undergoing oral and cervical HPV screening in sub-Saharan Africa, a negative scoping review. Dr. Oyerinde will be taking that presentation. Let's appreciate.
Good morning, Mr. Chairman, all my teachers and mentors. My name is Sunday Oyerinde Oladimeji. The co-author of this book, of this write-up, are Dr. Caleb Idowu and Dr. Aderemi, who are not here now. Our topic has been highlighted on the board. Oral health throughout the decade, science, service, and smile among HIV-positive women undergoing oral and cervical HPV screening in sub-Saharan Africa in negative scoping review. Next slide. Sorry. I've pressed something. No. Okay, thank you. HIV-positive women in sub-Saharan Africa experience a disproportionate burden of oral disease, persistent risk of HPV infection and cervical cancer, which is a leading cause of mortality among these women. While integrating HIV and cervical cancer screening programs are expanding the oral role of oral health, as well as the clear association with immune status of HPV-related lesions, including HPV-related cancer, and overall quality of life remain overlooked. We got to know this when we are trying to get a proposal, and we need to look for more literature. Unfortunately, we search. And clarifying how oral health is integrated into the cervical cancer screening framework is vital for advancing comprehensive women health care. Please help me. Okay. Thank you. We understand that oral hair cervical cancer as well as HIV, there's a bilateral direction to them. And at the center, there are a lot of morbidity that is highlighted. And again, we discovered that HPV infection cut across all of them. And even when we are looking at HIV, it is important to know that cervical cancer is one of the cancer related in HIV. And a lot of things have been said about the oral as well as dental cancer now, which are HPV related. Unfortunately, we discovered that there's nothing like an integration of these three topics as well as their effect. So it informed our objective. We did a map to map available evidence on oral health among HIV positive women undergoing cervical cancer screening in Sub-Saharan Africa and to identify critical gaps in research and service delivery. The methodology we use asking at the O'Malley framework, which is a form of systematic search, were conducted across PubMed, Scopus, Web of Science, African journals online, and a great literature for studies published between 2000 and 2025, to be precise, August 2050. We use it. A LB study involved the HIV positive population in Sub-Saharan Africa, including Nigeria, and reported oral health outcome in the contents of cervical cancer, HPV, or cervical cancer screening. We used title abstract and the full text was screened independently by two reviewers, and the third reviewer served as a check breaker. Data were charted by study design, population outcome, and the integration were used. And we even went to an extent to know if there is quality of life being reported among these people, if there is any morbidity that's being highlighted. We use Prismascopy review guideline to inform our report. What we found is shocking. We got about 1,236 recorded screens. Only 11 met the inclusion criteria, which include the population. Is there any study that have been used to, that involve all these aspects we are looking for in terms of screening? It is so unfortunate that none examine oral health within the cervical cancer screening. All what we found was a system study focused on either oral manifestation of HIV or cervical cancer screening optic without integration. There was no programmatic or interventional model address oral health within the cervical screening framework. So, thank you. The negative scopy review demonstrated a major evidence gap at the intersection of oral health, HIV, and cervical cancer screening in Sub-Saharan Africa. So therefore, it is important why we need to do interdisciplinary research and integrated service model are urgently needed to strengthen the science, service, and smile in women's HIV and the cervical cancer prevention program. So, thank you.
Thank you very much, sir. Don't want to misrepresent the title, so we are looking for it. So the paper was Oral Health Throughout the Decade, Science, Service, and Smiles Among HIV-Positive Women Undergoing Oral and Cervical HPV Screening in Sub-Saharan Africa, a negative scoping review. The authors tried to show the relationship between the trident of HIV infection, HPV infection and its sequelae, and oral health, and tried to make a case for oral health screening in the management of HIV or HPV infected people and HPV screening. They did a scoping review and unfortunately found that this is not the practice anywhere. From over 2,000 papers that they initially pulled out, they only found 11 that met inclusion criteria, which does not speak too well of the quality of work done. But we know the authors have attempted to do things properly because they use Prisma reporting. Abi? Yes, so we thank them for showing this gap in knowledge because this gap has been very well documented and very well shown that there's a gap in knowledge there. They advocated for joint research, I probably think with dentists and people in ONG. Thank you for your study. Thank you.
Something must start somehow. We want to, maybe we have comments and questions. But apology, we were just told about some minutes ago that there's a paper from Lagos. Please. It will be the last one, the very last one. Very last one. Comments? Questions for Dr. Yonide and his team?
Like we are discussing about dentistry. The ONG department, they are all, opening. Am I right in the mouth? So, and I think it's something that is very good. And I want to encourage you, the ONG, to do more of this so that people will know that your patients are suffering, from the mouth too. And we've said it here that we need to bring in medical students, to come throughout their training also in a dental school, so that they will understand what is going on. And I think that is very, very good. And I want the faculty to encourage this kind of research with the dentists and the ONG to come together and do more research, and this will help us a lot. So thank you very much from the ONG department. We are very grateful.
Okay. So we go to the last paper. The last paper is from Lagos, as I said earlier on, and it's from the Department of Oral and Maxillofacial Surgery, Lagos University Teaching Hospital. And the topic is deep fungal infection of the orofacial region, a series of cases managed at the Lagos University Teaching Hospital. It will be presented by Dr. Galato H. Can I have your presentation?
Right. Thank you very much, Mr. Chairman, and good morning or good afternoon, my teachers and everyone present here. I bring us greetings from Lagos and also from where one of a member of this great alumni association is doing wonders at the Lagos University Teaching Hospital. So thank you so much for the privilege to present this paper or this finding at our institution. So it's a case of a deep fungal infections which affecting the orofacial region managed at the Lagos University Teaching Hospital. So as a way of introduction, deep fungal infections of the orofacial regions are really not common. They are mostly opportunistic in the setting of most of the times immunocompromised states. In the oral maxillofacial region, these infections can principally be attributed to mild infections such as oral candidosis, as well as other life potentially threatening opportunistic fungal infections such as aspergillosis, mucormycosis, blastomycosis, and histoplasmosis. Deep fungal infections of the maxillofacial region typically present as chronic mucosal ulcerations and granular soft tissue overgrowth. And due to the specific nature of these presentations of these infections, they can and are usually could be misdiagnosed as malignant lesions. So therefore, it's crucial to obtain a thorough clinical history, and tissue biopsies would render this diagnosis. So microscopic examination of the specimen from biopsies or swabs is essential in the diagnosis of and also differentiation of these pathologies. Awareness of these unusual conditions would help the dental and also the medical practice proper and necessary multidisciplinary care required for these patients, which will also minimize the morbidity and at times the mortality. So we reviewed cases of orofacial deep fungal infections managed at our institution, and it was basically a retrospective study which we collated from records within the institution. And inclusion criteria was basically histologic diagnosis of deep fungal infections. And results, we found that there were a total of 5 cases within the study period, which was managed within this period, and all patients were males, interestingly, ages 27 to 60. Our most common presenting complaints were unilateral midfacial swellings and nasal discharge, which could mimic most of the times the malignant conditions too. Case 1 had uncontrolled diabetes, and also case 3 had another comorbidity, had CKD. All patients had intraorbital extensions of the lesion, and with 2 patients even presenting with loss of vision on that affected site on presentation. So also interestingly was found that aspergillus infection was the most common cultured fungi. Voriconazole was the most common medication or antifungal used, and all patients had surgical debridements, very maxillectomy, because that was the affected region. 2 morbidities were recorded, and this is just a summary of what was found. So we could see from the age, as earlier stated, and then males, of course, presenting complaints were more of the facial swellings, and common to all were nasal discharge. Some had loss of vision at point of presentation. Comorbidities, about 2, case 1 and case 3, had comorbidities which were diagnosed before the diagnosis of the deep fungal infection. And of course, like we said, aspergillus was the most common fungal infection that was diagnosed. Treatment was both surgery, combination of surgery, and also antifungal medications. And then the outcome, as earlier stated, 2 did not survive. So these are clinical pictures of these patients. We could see from case 1, case 2, case 3, most of them presented with the facial swelling, nasal discharge, which could mimic some malignant lesions, most especially antral CAs, and there could also be diagnostic dilemmas in such cases. So deep mycosis are relatively rare in the orofacial region and are thought to arise from either local inoculation and also or dissemination by hematogenous or lymphatic spread. Deep fungal infections of the oral cavity and perioral structures have been reported in a variety of anatomic sites, basically in the alveolar process, within the palate, and also the tongue. These cases which we discussed were stated the symptoms which they presented with. So, though infrequently reported in dental and medical literature, clinicians are often unaware of this clinical spectrum of this disease, and which may lead to delayed diagnosis and also negative impacts of the prognosis. So it's important to note that while diagnosis may be initiated in dental setting, multidisciplinary care with immediate referral to an infectious disease specialist and co-management is imperative to optimize management and promote a favorable outcome. So in conclusion, a high index of suspicion, prompt diagnosis, adequate medical and surgical intervention, and are important in the successful management of these deep fungal infections of the orofacial region, as these conditions may mimic conditions such as oroantral squamous cell carcinoma and cervicofacial necrotizing fasciitis. Thank you very much.
Thank you very much. Deep fungal infection of the orofacial region, a series of cases managed at the Lagos University Teaching Hospital. Well, I think the takeaways from this case series are that deep fungal infections of the orofacial region are usually opportunistic. They are associated with things that reduce immunity, especially diabetes, and that they may mimic, there may be a diagnostic dilemma in their treatment. I noticed that an antifungal was used, I believe IV antifungals. I'm constrained to add that topical honey would amaze you. We found that out in my center. And that, well, they have a high mortality. This is a 40% mortality that was reported here. Thank you for your presentation.
Thank you. Questions? One, two. Where's the third one? Okay. Okay. Let's start from the lady in yellow. Yes,
Okay.
please.
Thank you,
No.
Doctor.
Okay. Okay. Professor Lasisi.
Thank you, Dr. Ngalato, for the presentation. I'm just worried.
Introduction,
because,
ma. Introduction.
Sorry, I'm Taye Lasisi. I graduated in 2003. So I'm worried about 3 out of the 5 cases who were younger, below 40, and no comorbidities. I just want to know, did you find out, or did you bother to know what other things could be responsible for these conditions in these younger people? I think, and even the microbiological analysis showed almost the same thing, but they were younger and there was no comorbidities in them. Thank you.
Maybe we take all the questions together because of time. Yes. Professor Adisa. After that, Professor Adisa.
Thank you, presenter. Dr. Salako Mariam, 2011 set. So my question, we have some of the, you said your case series was about a span of more than 20 years and the 5 cases. So I'm just wondering, in your treatment, okay, you use antifungal and you said you did some surgical debridement. Was there no case where you did some maxillectomy with it or just debridement and the patient was able to function afterwards? No prosthetic rehabilitation afterwards? And also, here in Ibadan, we wrote a case about a patient which initially the diagnosis wasn't so clear. At the end of the day, we were made to know it was a fungal infection, and after the nibbling, debridement, there was no teeth left. So we had to improvise, went to Induti Theatre, Professor Fashola and my Professor Dosumu. I was there with them. We had to take an impression and try and work things out using the soft tissue undercut to get a prosthesis for the man. I'll have to trace and do a follow-up. But presently, we have another patient, no comorbidity, like 42, looking man. But this patient was managed, he's presently being managed with the ENT, ENT referred to us. We had to just for something because he has been on NG tube for so long, and the wife is getting tired of feeding him with the NG tube. So we are presently working him, and we've given him a feeding plate, but with the bulb, and we are monitoring him. But also, topical antifungal has to be used for him to be placing the prosthesis in the mouth. So his quality of life has really been improved with the prosthesis. So you don't just stop at the surgery. Rehabilitation of the patient afterwards, quality of life matters a lot. Thank you.
Thank you. Professor Adisa. It is really a challenging fungal infection of the, yes.
Thank you very much, Dr. Ngalato, for the presentation. I'm Akinyele Adisa. I graduated in the year 2000. So the problem with deep fungal infections, like you rightly said, and probably Dr. Salako also mentioned, is the diagnosis. And that is where my own question is. Because we have seen a few cases here also. The problem is that on histology, you really cannot see anything clearly the first time. And you wonder whether this is just soft tissue edema or something reactionary, nothing specific, until you begin to suspect after probably 2 or 3 biopsies that, okay, could this be a deep fungal infection? And then you do a special stain. But most of the patients present very late because they have done all sorts of management. And then coupled with the difficult diagnosis, it takes a bit of more time to reach the final diagnosis. So in your series of cases, did you find anything
mentioned about early index of suspicion. Is there anything that you saw that could probably alert us early enough? Something you mentioned repeatedly was this nasal. Was there any thing specific about the discharge? For example, you said it mimics malignancy. Is it that they were bleeding, or was there a particular type of discharge that the patients presented with? So that if we see people with facial swellings around the maxillary area with specific sort of discharges, probably can alert us early enough, and then we'll know that we need to do special stains right away. Thank you.
Dr. Galaton, you can address those questions.
All right, thank you very much for these questions. I'll begin with the first from Prof. Well, we found out that, and that's why we are calling the attention of the medical community to the fact that in as much as it's been found in times past that immunocompromised individuals are at risk, but recently which she has corroborated also, that there's someone currently who is also presenting with a similar finding, and there is no overt or immunocompromised state. So these 3 patients who were diagnosed to have this were actually without any immunocompromised state. So it is important that in as much as we click and we find out that these patients do not have any form of immune compromise, that does not rule out the fact that we would not entertain the diagnosis of deep fungal infection. So there wasn't something specific for these 3 patients whom we investigated or we managed. The second question was with regards surgical interventions. Yes, the surgical intervention, I mentioned that it included maxillectomies. We had to carry out maxillectomies for the patients because it was involving, in short, some of them had gotten even up to the inferior orbital fluid. They would involve the bone, and so it's important. Rehabilitation, of course, very important, which was part of the management. And I'm happy you also corroborated the fact that such similar suspicion is being entertained also here. For the last, which is any special finding, because we said it mimics malignancies. So the findings were sincerely very similar to that which patients with antral malignancies could present with. And so that is also the reason why we're bringing it out, so that we do not completely just continue to concentrate on the fact that the patient is presenting with a malignancy. Even for primary healthcare centers or secondary healthcare centers, it's important to begin to investigate as early as possible. One of the things which we were able to, really tie down to fungal infections is the fact that the constitutional symptoms which could present in malignant settings are not they are not so much present in that of the deep fungal infections. And so the constitutional symptoms could help, but in terms of specificity in the discharge, the swellings, that was really not clear in terms of the diagnosis. But it's important that a high index of suspicion. So immediately we have such symptoms, then we begin to entertain a wide variety of diagnoses and not just malignancies. We didn't just end up at histological diagnosis, also tissue cultures, inviting the microbiologist as early as possible, which could also help to aid our diagnosis as soon as we could. So those were our findings and the responses to the questions. I hope I was able to clear the air. Thank you.
Okay, thank you, Dr. Galato. You have done well. Really, a case of fungal infection is very challenging to the maxillofacial surgeon. Some quick announcements. We are happy to announce to you that the dental school now has an anthem. We have an anthem. You are not happy. So the LOC chair has said that we must learn it before we leave this room. Posters are outside, and concurrently the tea break will go along with the poster. At least you can have a look at the posters. So at this point, we want, the rapporteur and I, we want to thank you for the privilege that you have given unto us, even to, undo this particular program. I don't know if there are other announcements from the LOC. So if there are no announcements, I think the dental anthem can be this. But you have been a very, very wonderful audience. Very, very wonderful audience. So anthem.
The anthem will play shortly.
In Unibadan's heart, where knowledge gleams, is the faculty of dentistry fulfilling dreams. 50 years strong, we rise and strive. With clinical skill, we keep hope alive. With innovative research, we pave the way. The rules of the past and strong foundation, the clouds of tomorrow shining bright. Honoring our legacy, we're standing tall. Admiring our tomorrow, we hear the call. The rules of the past and strong foundation, the clouds of tomorrow shining bright. Honoring our legacy, we're standing tall. Admiring our tomorrow, we hear the call. Admiring our tomorrow, we answer the call.
Please, let's do this one more time. Please, so that the lyrics will go smoothly this time. So just one more time, Mr. Sunday.
In Unibadan's heart, where knowledge gleams, is the faculty of dentistry fulfilling dreams. 50 years strong, we rise and strive. With clinical skill, we keep hope alive. With innovative research, we pave the way. The rules of the past and strong foundation, the clouds of tomorrow shining bright. Honoring our legacy, we're standing tall. Admiring our tomorrow, we hear the call. The rules of the past and strong foundation, the clouds of tomorrow shining bright. Honoring our legacy, we're standing
of school. So please, we'll have the tea break, the poster presentation, group photography outside, and we are going to come in shortly for the interdisciplinary session. Please, thank you so much for coming. Thank you. Please, let's see the posters and the pictures outside.